all for joining this evening for our collaborative meeting for the Michigan Kidney Improvement Collaborative. I think I know most, or if not all of you. My name is Michael Hung. I'm one of the nephrologists here at University of Michigan and the program director for this initiative. So our agenda today, just do a little bit of introductions through the collaborative. Again, I think a lot of us know each other, but I think it'd be nice just to refresh. We will go over some of the year 2 requirements as to participate in this collaborative. And then we'll present some data. We will go over what we have. I will tell you right now, there are some limitations to our data. We're not where we want to be, unfortunately, with that, but we will share what we have as well as where we hope to be in the future. And then we'll leave hopefully plenty of time for discussion towards the end to talk about what each of us has learned that maybe we can share with each other during this collaborative process, as well as how we can help as the coordinating center, whether it's through materials or other education or other things, and then also some future directions as to where all of you would like to see this collaborative go. So just a quick reminder again, Michael Hung. Rajiv Saran is here with me. He's my co-director, also at University of Michigan, and Dr. Julie Wright is the real quality improvement expert. She's actually a systems engineer by training, so we're really pleased to have her on our team to help work through all the challenges that come with quality improvement in the clinical setting. Just a reminder that the initial primary quality improvement goals of MKIC were around 2 major factors. The first was the prescribing of these more novel diabetic medicines that have really been shown to have significant benefits in patients with diabetes and kidney disease, specifically the GLP-1s and the SGLT2 inhibitors, and also to increase urine albumin testing. I think this audience is, I don't need to explain that to this audience, the importance of albuminuria in terms of risk stratification for our patients. Again, why focus on these medicines? Because they have, even though they started out as medicines to really focus on glycemic control and management of diabetes, in recent years, they've really emerged as much more important drugs than just their effect on glucose. They have significant cardiovascular benefits, both classes. The SGLT2 inhibitors have now been shown in numerous studies to have very significant benefits in terms of delaying chronic kidney disease progression and even hard renal outcomes like end-stage renal disease, and as well as overall mortality benefits. They both classes of medicine also help promote weight loss. So these are pretty exciting medicines, I think, for our field in managing patients with diabetes, which is obviously one of our biggest contingents of patients with kidney disease. And this is just a reminder of some of the materials. Hopefully, again, you guys are all very familiar with these materials. These are available at the website mct2d.org and under the resource tab, where you can download some information. There are handouts there that include a quick summary of side effects to refresh and use as a reference. And then we have information like this that we're updating all the time to show the latest coverage patterns for the SGLT2 inhibitors and GLP-1 receptor agonists through some of the major payers in the state. And again, later on towards the end, we'll be asking you guys what other materials we can help develop for you to help in your daily practice, managing patients and getting patients on these medicines and achieving these goals. So this is who we are as a collaborative to this point. We have 15 nephrology practices across the state of Michigan. Actually, we also just recruited one new one for the second year to join. with the new practice, I think we are around 45, if not 50% of the nephrologists in the entire state of Michigan. So that's pretty exciting that we have a really good quorum and can continue to work together on these projects. So with that, I thought we could go around and do some brief introductions for the practices in particular. Maybe just share your practice name and where your main office or offices are located. And then one thing that you could say you've learned about either the SGLT2 use or GLP-1s in the past year, something quick that maybe you want to share with the rest of the group. Anybody want to go first? Wajdi, are you still there? Oh, Paul, you want to go ahead?
Yeah. Hi, it's Paul
Yes,
Berkowitz. I'm the champion for the Practice Nephrology Associates of Michigan, and we're based in Ypsilanti, Michigan. And what I've learned, I suppose that it is indeed difficult getting prescriptions approved by insurers. And I want to hear everyone's opinion. I guess what I need to learn is especially on the lower end of risk, exactly who we should be prescribing to, people without albuminuria, this issue of slope analysis and things like that.
Great. Thanks, Paul. Wajdi?
I'm Wajdi Al-Shwayat of Lake Michigan Nephrology. We're in the west side of the state, St. Joe, just across Chicago on the lake. So what I learned, it's on the opposite spectrum. The insurance can cover it. Sometimes we can get some free supply for like up to few months. On the other hand, I learned more how patients are happy with the GLP-1, especially with the weight loss. Yeah, so it's been challenging sometimes to get it covered by the insurance, back and forth, switching between medications, but we can get some supply here or there.
Great. Thanks, Wajdi.
Thank you.
Hi, this is Dr. Madawi.
Mm-hmm.
Hi, I'm a nephrologist in Flint and Lapeer area. So I think the addition of both groups of agents has helped big time, actually. And what I found, it's encouraging for the patient when you try to prescribe with it a continuous glucose monitor, and they see the difference in their blood sugar. The only issue that I'm having, even with the resource of the insurance, I think it's very helpful, can give you an idea. But the issue with the amount of payment for the patient that end up paying out of pocket will depend on the tier of the medication. So I'm not sure how easy, if that information, if we can say like this medication is going to be a tier 1 or tier 2 in that insurance, because most of the time, most of them, they are covered. In most of the insurance, as we see that the chart is turning green all over.
Yep.
But the issue is going to be how much the patient ending up to pay out of pocket. So if we can get a sub-classification in each insurance, is it a tier 1 or tier 2? Which one is going to be affordable for the patient? That will be very helpful.
Okay, that's a great suggestion. I agree with you. It's become less about actual coverage and the prior auths and more about the tiers and the actual out-of-pocket. So when we first looked at that was very challenging, just because of the number of different insurance, different plans, and different tiers. But it's certainly something that we can explore. So I really appreciate you mentioning that as well. Dr. Butcher?
Yes, hi. I work in Bay City. I'm with Dr. Marchena with dialysis and nephrology consultants. And One thing that I found interesting over the past years, I'm really seeing a lot of people get started on the SGLT2 inhibitors when they're in the hospital. That really surprised me. But I see a lot of it both for CKD and for CHF patients.
No, that's really interesting. I think we've seen a little bit of that, but not as much. So if anything, we sometimes see the opposite. They get stopped in the hospital and then not get restarted. But that's an interesting observation. We should explore that a little bit more. Thank you.
Mm-hmm.
And I think Dr. Osama, did I see Dr. Osama on? Dr. Osama, are you there or? Okay, we can come back to that. Did I miss anybody? Anybody else want to make any other comments?
Hi, my name is Susan Bartis. I'm the Clinical Quality Programs Manager at Great Lakes Physicians Organization, and I work with Dr. Marchena's office and Dr. Butcher. So I'm just listening to the call tonight to see what I can learn. I've noticed that working with the primary care physicians and the specialists, there is an increase in the prescribing of the medications. It's interesting at the beginning of the year, not only co-pays for the patients, but because deductibles are high, they may have a very high copay until they meet that very high. Well, yes, the copay. For instance, I know of someone who's had a $1,600 copay for a 3-month supply. And I've also noticed that Ozempic right now, I was told that there is a shortage of Ozempic, that they're only filling 1 month at a time because there is so much being prescribed for weight management. So that the prior auth will be added back on for the type 2 diabetics.
Oh, wow. Yeah, thanks for being here, Susan. I really appreciate your perspective. And yeah, we've heard about different drug shortages, especially around the Ozempic, which is yet another limiting factor. But hopefully we'll be able to get beyond that as well. I do think it's gotten a little bit better from what I've heard, but it was a rate limiting step to its use for a while there.
My name is Shelley Schneider. I'm the MCT2D program administrator for Professional Medical Corporation. We're a PO in Flint. And Dr. Osama and Dr. Madawi are part of our group. So I work with the endocrinologist in all 3 nephrology practices in Flint.
Great. Thanks for being here. And I think I just saw Dr. Luthra join. Dr. Luthra, did you want to mention, we're just doing some introductions about the practice, your practice location and name, and maybe one quick thing you've learned about SGLT2s or GLP-1s in the past year. Okay, you might have stepped away. I think Dr. Osama?
Yeah, hi. Yeah, we've been using quite a bit of those, and really it's popular among patients. They've seen some of the ads on the TV, so they accept it very easily. Of course, the coverage issue, availability issue, as you know, especially for the GLP-1 agonists is a issue, but we're able to switch them around, like Trulicity is sometimes more available.
Great. Yeah, no, it's funny you mentioned the advertising, because I do have many patients mention that as well, and some of them bring it up to me before I can bring it up to them. So whoever's the advertising executives for these companies are clearly know what they're doing. So hi, Dr. Luthra, how are you?
Good. How are you?
Good. We were just doing some introductions. If you wanted to mention your practice and maybe one quick thing you've noticed or learned about GLPs and SGLT2s in the past year.
Sure. So my practice name is Kidney and Hypertension Specialist, and it's located in Jackson, Michigan. And the biggest thing I've learned, at least in Jackson, the primary care physicians are a little bit hesitant in using the SGLT2s. And of course, the insurance issues. I was on the conversation on the phone while I was driving, so I was able to hear you guys. And the insurance issue is still an issue, especially the copay. It is more and more approved, especially Jardiance, I think, is a little bit more approved compared to Farxiga. But the patients do have a huge copay.
Yep. Yep. Seems we're hearing a lot of common themes from people, which makes sense, of course.
Right.
And you know, those are certainly things that we've tried to advocate for and will
sure.
continue to do so. Not quick changes, as you can imagine,
Right.
but things we will continue to work on. So,
and I do want to say, you know, I've been using it. Another thing that I've learned, you know, of course, I've been using it in non-diabetic proteinuric diseases also, especially IgA nephropathy. And, you know, I just started somebody with fibrillary GN on it because she's got a lot of proteinuria, you know. So
yeah, no, I think there's more and more emerging
Yes.
data. You know, at Kidney Week this past November, the EMPA kidney study was published and presented, and
Right.
we're starting to see more evidence that maybe this is not exclusively diabetes. And of course, these medicines, or at least SGLT2s, were used a lot in heart failure as well. So
Right.
lots of non-diabetes type indications as well. And that's, again, it's a great example of something that we can talk about as potentially a future direction of
For
this
sure.
cooperative. You know, right now we're focused on the diabetes just to plant the flag and to begin with, but certainly, hopefully, our non-diabetic patients also benefit from this as we all get more comfortable with these medicines. Great,
Yep.
Thanks everybody for those comments. Again, please feel free to jump in anytime as I'm presenting with any questions about data or any comments or anything that comes up. So the year 2 value-based reimbursement requirements, or the VBR requirements, hopefully this has all been shared with you already, but the requirements are going to include attending an in-person spring regional meeting. And that's not everybody in the practice, that's you guys, the clinical champions. We have those, we have a slide with those dates at the end. The nephrology clinical champion meeting, we're hoping to have our own meeting again with hopefully all the clinical champions in nephrology to in the fall, hopefully in person, so we can really get together and mingle a little bit more and chat a little bit more. We're asking people to complete a progress report survey. I promise it's not too onerous, but it is important for us to, again, learn from how every practice is doing. This is a great follow-up from what Dr. Luthra just mentioned. We're going to have an educational session focusing on the emerging uses of SGLT2s and GLPs. So we'll review some of the data for non-diabetes at that point and further expand on things we've learned even within the last year. Continue to respond to any requests from the coordinating center about any work related to this collaborative, and then to potentially present on what you've been doing in your practice at our collaborative meeting. So let me know any questions about these requirements for year 2. One thing that you may notice is that there are not specific clinical targets at this point. That is something that eventually we will likely want to get to. But as I move to the next section where we talk about data, we're not quite where we want to be with the data. And we're not going to hold practices to data metrics until we feel very comfortable that we're getting good data from across the practices, across the POs. So that is not going to be part of the year 2 VBR, but it is something that we have discussed in the past and will probably look to in the future. So I'm going to go ahead and present some of our data from the nephrology side of MCT2D, so the MKIC specifically. Just a reminder of what we're talking about. we're focusing just on patients with type 2 diabetes mellitus, which has been defined by diagnostic code or labs meeting the diagnosis or use of medicines for diabetes. And they had to have been seen by one of the nephrologists at least 2 times in the past year. It's important to note that unfortunately we still have some significant limitations with the data that we're working through, and we will present some information as to where we hope to be in the future. But for right now, we only have claims data based on Blue Cross patients for the PPO and Medicare Advantage. So even though when we first started this collaborative and all of the Blue Cross value partnerships or CQIs are meant to be all payer, all patient. Right now, the data I'm going to present is limited to Blue Cross, but certainly we have plans to get full data. We want the benefit to be across all of the patients, not just to the Blue Cross patients, of course. We've had some issues working through some labs coming across without a defined unit, so we've had to work through some data issues like that, and just incomplete data reporting. So that'll become kind of obvious as we go through some of this data, and but I just want to be upfront with those caveats as we move through this. So the first, when we use pharmacy claim data for diabetes medications, this is where we're at on a collaborative wide level in terms of the breakdown of the different types of medicines that our patients with diabetes are on. The denominator here is 1,164 patients across the collaborative right now. The most commonly used medicine is metformin, and followed by insulin. SGLT2 inhibitors just short of 9% right now, and GLP-1s 8.1%. When we look at a comparison of the nephrology patients versus the primary care physicians that are also part of MCT2D, you'll see some differences here. Many more patients on metformin, for example, which is probably not a surprise since it's contraindicated in many of our patients with more advanced CKD. We're a little bit behind with the SGLT2 inhibitors, and again, maybe some of that is uncertainty in more advanced CKD, and we're significantly behind in GLP-1, which I think is something that we'll probably work to catch up on. Pretty similar in other areas. And by the way, this does not denote who is prescribing these medicines. This just means what the patients are on. So it could be prescribed by nephrology, could be prescribed by primary care. It counts the same. And then this is specifically breaking down the SGLT2 and GLP-1s. So patients, just looking at these two, just on an SGLT2, 5.4%, just on a GLP-1, 4.8%, either is 10.2%, both is 3.3%. And this is the same data, but comparing to the primary care contingent as well. So again, more patients on either one of these in the primary care group at this point. So moving forward to clinical claims, this is where we start to unfortunately lose some of the data. We don't have as complete lab values at this time. We will present you what we have. You'll notice immediately that we only have hemoglobin A1C values on about half the original cohort. But of that, of the values we have, this is the mean and median A1C values that we're seeing in our cohort. And this is broken down by practice. We've anonymized this, but you should have received information as to which one of these your particular practice refers to, so you can see this data here. Again, we're presenting this because in the future, we certainly hope to be able to present practice-specific data like this and have a designated report just for practice 3, for example, that really breaks everything down. But right now, you can see that the number of patients goes down quite a bit into each practice, depending on with this breakdown, just because of incomplete lab data at this point. So this is still somewhat preliminary, but it's where we hope to be, and we wanted to show this as where we're heading. This is stratifying the A1C values by age in the 65 and older versus younger than 65. Not huge differences, maybe a little bit higher in the younger group, and not a lot of difference by gender as well. This is basically showing that similar data, but across both categories, age as well as gender, and similarly not a lot of differences by age and gender. With weight, we see the distribution again, mean of 205 pounds. And this is the distribution of weight in the patients in our collaborative. Again, not quite the complete cohort, 679 patients. This is the breakdown by practice. Again, some of the numbers are a little bit inconsistent just as we work through data reporting and getting more complete data in the future. This is another way to look at it by body mass index. This is the mean and median for all the patients in our collaborative. Again, we see some range here, but again, I would just point out that you see some significant drop-offs in ends depending on reporting. So we again recognize that this is not perfect data that necessarily represents, there's necessarily a good representation across all the patients in your particular practice. But as we go forward and hopefully get more data, we will be able to provide a more complete picture for you. This is the breakdown by GFR. Unfortunately, again, you see that the numbers drop even more significantly. I know that all of our patients have eGFR values, so it's not that we're not testing for these, obviously, but getting them across to us and properly attributed to the right practices is the technical background work that we are still working through with our data vendors. But with what we have, again, limited number of patients, but you can see the mean and median eGFR values here. And again, the numbers get pretty small. So even though we showed this just for example, I wouldn't read too much into it. I mean, even it looks like you have these huge ranges from 15 to 70, but again, small numbers. So not something that we're considering conclusive or anything like that at this point. This is the breakdown by stages of chronic kidney disease. So probably not that surprising. A lot of patients in the stage 3B or worse range. And looking at the albumin to creatinine ratio, the numbers are even lower. So we have high numbers, but due to some skewed values in the mean, the median is only about 62. And we didn't try to break that out by practice because the numbers are just so small. Going forward, as we start to get more robust and more complete data, especially the clinical data, we hope to break things down more like this. This again is we're calling this pilot data because it's got limited numbers, and you can see the ends here are pretty small. But eventually, we'd like to be able to show you both for the overall collaborative, of all the patients that we have, how many are in, for example, stage 3B CKD, and of those, what percent are on SGLT2s, what percent are on GLP-1s. Right now, the denominators here are pretty small overall. So again, we're not holding these numbers as set in stone, but this is an example of where of the type of data we plan to show, both collaborative wide and for your specific practice. This is a breakdown of medicines by A1C. So if the A1C is less than 6.5 or greater than 6.5, not huge differences right now. Most of the patients fall in this group where the A1C is greater than 6.5. And also by BMI, several of you alluded to the positive benefits of especially GLP-1s on weight loss. And so in the future, it'll be important to look at BMI and weight and see what the breakdown of medications is and what trends we see there. So I've kind of alluded to this already throughout the data part of the presentation, but we're really looking to get a larger sample size. So what we've presented is we hope is just scratching the surface in terms of the type of data that we can share with you in the future, specific to your practice. As we talked about last year when we started the collaborative, we also hope to develop opportunity lists for your practice as well. Lists of patients that meet criteria that don't seem to have any contraindications to SGLT2s or GLP-1s that you can use in a more targeted way as the practitioner or working with your quality improvement experts or your practice managers and nurses and other staff to really target getting patients onto the medicine. Again, we want to get to the all-payer level where we can present really comprehensive data for your practice, not just for the Blue Cross patients that we have good data on for now, and also get more information about lab values. It's a little bit technical why we haven't been able to get more labs. I'm not sure I fully understand it myself, but it has to do with how patients are attributed to practices. So we definitely don't want to attribute, give a score to a practice when we don't feel, very, very confident that score actually represents your patients and your patient care of those patients. So that's what we're working to make sure, that patients are properly attributed to the right practices. So you're getting credit for what you actually do before we are able to have those kinds of metrics. And with this last pilot data showing the crosstabs of different medication use across different clinical stratifications, just so we can look, should we be doing more in patients that are morbidly obese, as one example. And then, as I said, the opportunity list and having a data dashboard. We just felt it would be preliminary to put up a dashboard with this incomplete data at this point, but this is where we hope to be going forward. And the timeline for that is, in this past year, we're getting the preliminary data extract, but we're limited to only the Blue Cross data, as I mentioned. This year, especially in the second and third quarter, going into the fourth quarter, actually, we'll be working on data retrieval for all patients and having the proper attribution. So that is the next key step. It will probably still be focused on Blue Cross data, but it will be more complete than what I was able to just show you. And then going into next year, that's when we really hope to be hitting our stride and getting full data across the patients in your practice, all payer type data, and really filling out these reports for you. Let me kind of pause there, see if anybody has any questions on data, and then we can move towards the broader discussion topics.
I have a question. This is Dr. Madawi. I have a question about how often do we do albumin to creatinine ratio in nephrology practice, especially if the patient is a CKD or proteinuria CKD. So the absence of albumin to creatinine, is it going to be taken negatively on us while we are continuing to check for the protein to creatinine ratio?
Yeah, I think it's a good question. And right now, again, as you saw, we have not set any specific metrics in terms of percentages and things like that. And even when we get to that point, those metrics will be based on relative improvement from your own baseline. Okay, so that's the first thing. The second thing is, right now, I would say that once a year at least for urine albumin to creatinine ratio, that's what the HEDIS measures are, the guidelines for patients with diabetes as part of the screening. So that I would say is the minimum. I think that many of us will check it a little bit more frequently, especially as a marker for evidence of improvement. So I like to see the albumin to creatinine ratio go down after I've started somebody on an SGLT2 inhibitor or even an ACE or ARB, and hopefully that's a sign of improved prognosis. It's feedback I like to give the patients. So I will recheck that on a follow-up visit as well. And then to your third point, I think about the protein to creatinine ratios versus albumin, that is something that we will certainly take into account. I agree with you when you have somebody with overt proteinuria, where the protein to creatinine ratio is greater than 1, there probably is not much value added to the albumin to creatinine ratio. That is part of the data that we have to work through as well. Did I answer your questions about that?
Yes, I think so. So at least if we can have that protein to creatinine to replace on those patients with proteinuria kidney disease, I think that would be easier, because it's unlikely for me, if someone has already 5 grams of protein, to go back and check the albumin.
Yeah, no, I think that's a fair point. Yeah. Any other comments about the data aspects? Okay, so moving forward to the group discussion for the rest of the time, we'd really like to get your additional feedback and thoughts on future directions. So first, just to follow up on what we kind of started earlier with our introductions, any really particular helpful lessons that you learned, good or bad, things that you were definitely helpful, things you definitely would not do again, that you might offer as advice to colleagues here? Anybody?
Try not to coordinate data across an entire state. You probably learned that one already.
We're not giving up on that one. No, it's the data is there. Frankly, I mean, you guys all have the data. The POs report data. There is a central data repository. It's just like I said, I can't claim to understand all of it, but it's more technical. This is also, frankly, kind of uncharted territory for the CQIs, the Blue Cross Value Partnerships. I might have mentioned this, at some of our introductory meetings last year, but when like all the other CQIs have been not chronic disease, they've been more, episode of care, like surgery or something, and they all have data abstractors. So they all have people sitting around collecting the data that they want, and feeding that into a database, which is more like almost like a clinical trial, right? And it's more reliable, but it's very labor intensive. And I don't think any of us wanted that for this. And it's just not efficient for the type of data we're looking at, which is more longitudinal and frankly on orders of magnitude more patients than say bariatric surgery in the state of Michigan, right? Or even cardiac surgery. So for us to take existing data coming from different streams, different practices, different EHRs, and everything like that, and make heads or tails of it, and put it together. It's been a momentous task, to be honest, and we're not where we want to be, as I've said, but we're definitely, that is priority number one, what we've been working towards, and will continue to try to perfect. Anybody run into any major barriers other than the insurance copay issue that we all have faced?
So I had a patient with early diabetic nephropathy, just macroalbuminuria, and I started her on, I can't remember which one, but I started her on a SGLT2 inhibitor a while back. And, I usually try to tell my patients ahead of time, that your GFR will drop by 5 to 10%, but in the long run, it's going to help, blah, blah, blah. Hers kept on dropping, like it just kept on dropping. So has anybody else seen that? Her creatinine is normal. The only thing is just, macroalbuminuria, and she kept on dropping, and it dropped to the, she was more than 70, 80, and she dropped as low as 40. So I had to stop it. So I want to know if anybody else has faced a similar situation.
Did it get better?
After I stopped it, yes.
Anybody else have similar experiences? I can say that I have not seen quite that dramatic a drop. I've seen, what we expect to be a minor drop
Right.
in the GFR that stabilizes pretty quickly. As you guys probably all know from the literature, when they've done meta-analyses, the SGLT2s are actually associated with a lower risk for acute kidney injury. But I have heard from other people anecdotal stories like that, Dr. Luthra, where and certainly any drug can, cause an AKI, right? I mean, whether it's an AIN or something like that. But I personally haven't seen one that dramatic, but I think I might have heard about it from one of my colleagues, where they had to stop the SGLT2 as well. Yeah, but thanks for sharing that. That's certainly something to keep an eye on.
So I feel like that could happen if they have fully controlled diabetes and severe hyperglycemia. So they pay a lot. I mean, I wouldn't put it, if someone has really bad diabetic control and we put them on SGLT, they can be profound diuresis.
Yeah,
she actually is pretty well controlled. She actually is very well controlled, rather. So that is why I was very surprised, and I didn't even stop it. I kept on, I'm like, no, let's just check labs again in 3-4 weeks. But then after 2 months, I was like, no, we need to stop it. Yep.
Yeah. No, that's a great point about the glycemic control. I've not had too much problems like that, but I've seen that reported in the literature and by colleagues with like really poor glucose control. You have like really excessive osmotic diuresis, presumably, and more side effects. So some people do advocate for getting the glucose under control or under better control first before adding an SGLT2.
And as a counterpoint in your stable patients, have you discontinued checking creatinines as some experts have recommended?
Do you mean routinely checking after starting or?
Yeah, yes, not routinely checking. These are not ACEs or ARBs. I mean, do you do that with Norvasc? No, you don't. And so I guess, as you pointed out, it's actually reduced incidence of AKI. And, they would say in a quote unquote unstable patient, whether it be that patient with poor glycemic control, but, a stable routine patient, hey, you have some albuminuria, I got this great drug. Some people are now advocating it's really not necessary to recheck creatinines like that.
Yeah, I'm sort of in that boat, although it is still pretty routine for me to have them recheck like a month later. I agree. It's not like an ASARB where I'm also kind of concerned about the potassium and everything.
And do you wait a month or 2 months? Do you want to miss that acute
Yeah.
drop, which is actually good?
Yeah, no, I think that's a fair point. I usually still tell them a month, just because it's kind of convenient for them to remember.
I also try to check it between 4 to 6 weeks because I feel like if there's a drop, it's going to be an initial drop. So 6 weeks, 4 to 6 weeks would be a better reflection, you know, if it's actually, do you know what I mean? Like the temporary drop, like I don't want to worry about a week or two later. I'd rather just check in 4 or 5 weeks. By that time, it'll settle down.
Yep.
Is anybody else using it for non-diabetic proteinuria diseases? I mean, except IgA, of course. IgA, it's already, you know, there is literature out there showing benefit. Any other proteinuria disease such as lupus membranous or something else? Is any other physician using it? I'm just curious.
I've been trying to use it, and I'm just curious to see whether, you know, as a non-indicated use or whatever. I'm suspecting you can have a lot of trouble with insurance companies.
Of course.
I have tried it, and I'm waiting for the blowback.
Well, DAPA Farxiga has FDA approval for CKD, non-diabetic CKD, and I don't know if Jardiance has after EMPA kidney came out, but I wouldn't be surprised if that follows suit pretty quickly to have the non-diabetes indication. But at least Farxiga definitely does.
Yeah, I've been using it, but again, not long enough to really have an experience.
Sure.
I'm going to be curious, even you guys, Mike, what are you going to have in your denominator? You know, non-albuminuric diabetic kidney disease with, you know, stable over some prolonged period of time in an 85-year-old. You're going to add this medication?
No, those are great points. I think you could certainly make an argument, and I think that's clinical medicine, right? I mean, we have to use our judgment. 85-year-olds aren't the routine patients in those clinical trials. You can make that argument. Non-proteinuric, non-albuminuric, maybe not high risk. You know, you're not going to live long enough or to see the benefit because the risk isn't that high. So I certainly think you can make those arguments. In terms of what we do for the collaborative, the issue with the collaborative is there's only so many exceptions you can build in, right? So we definitely want to be realistic, and it's not just us at the coordinating center. That's why we have these meetings. It's to get the feedback from all of you. This is a collaborative. You all have the seat at the table. That's how this works, and that's the only way it works as far as I'm concerned. So I don't doubt that it won't be a perfect denominator. I'm sure there will be exceptions you could look at, but I think that's true whenever you try to do, you know, kind of a broad thing. All I can promise is that we'll try to set reasonable rules that you know, make it feel like we're doing the right thing. Does that make sense?
Yeah, and just, I mean, not even a collaborative. I just tomorrow sitting across from some 80-year-old who have been watching for 3 years and stable. You know, it's just a struggle, even in you know, my daily practice. You know, denominator aside, it's something that hopefully over time there'll be better refinement and better advice from the experts is what I should actually be doing.
Yeah, I agree with you. Those patients I struggle with too, and you know, they've been stable for quite some time. They seem to be low risk on the heat map. You know, are those the right patient? Do they need to go on these medicines? It's not entirely clear, I think, in some of those groups. The next topic we really wanted to talk about is really like what else we can do to help your practice. Obviously, last year, the big focus was on provider education, doing the webinars and providing the provider-facing type educational material like the handouts we showed earlier. One thing that we're pursuing this year is to have more patient-facing educational materials. So the side effect handouts, for example, they're really geared towards providers. They weren't designed to be patient-friendly, but that's certainly an area that we can explore and provide handouts to practices to make it easier to explain things to patients and give them written information, because obviously it takes time to explain all these things. But that's one example. I wanted to see if people have other ideas or asks of things that we can do to help with this process. Wajdi, do you think it would be helpful to have the patient education materials?
Yeah, that would be great if we can share it with patients. Sometimes we have specific concerns about UTIs, about amputation. We still hear this here or there. So if we have clear numbers that we can share, they'll be very helpful.
Okay, great.
The
We're
same
very
thing if we
fortunate.
have some updates about the insurance coverage, the label indication, anything that could go through easier. That would be very helpful. So
Yeah. Okay, great. We continue to advocate for that, of course. And as was discussed earlier, we can look into how feasible it is to provide information about tiers, and therefore a sense of copays. But there's layers of complexity there that I think make it hard to summarize in one spreadsheet or one document, because, for example, it depends on what the max copay is, or the donut hole, or what time of year it is. So there's all kinds of variables, but we can probably try to add a little bit more information just than broad coverage, and we are updating those when we see changes.
So I have something. I know that it's easy to get to the website, but each time that I bookmark the website to get back to it and to get the resources, sometimes I'm having difficulty. So what about, have you thought, guys, about having an app on the phone to be available, especially that it's not only we as a physician, there is other people that can benefit from it.
Yeah, that's a great suggestion, Dr. Madawi. We do have like a web developer on our team who might have some ability for like app creation. It's something we've thought about kind of farther down the line, but we'll absolutely keep you updated as we're able to make progress with that. And it's a great suggestion.
Yeah, thank you for that.
If you have anything that you'd specifically want to see in an app, we'd love to hear it too. Just, are you thinking with the app just to have a closer fingertip access to tools? Are there any other features that you could conceptualize that would be helpful to you or your practices? We'd love to hear them too. This is a perfect forum for that.
Exactly what you said is the tools that we use it the most, we as a physicians. So that exactly, I think, will be very helpful. Something that you just can tap, you can check the patient insurance without going back and forth to look where is that insurance is. So these things can be much easier if it's within an app compared to a PDF file that you're trying to find out.
Perfect. Thank you so much.
Great. Really appreciate, everybody's comments. Just wanted to, with a few more minutes, I just want to spend a couple minutes on any other things you guys would like to see MKIC work on in the future. Remember, this is our collaborative. This is our opportunity to really kind of decide what we think is important. Obviously, we focused on albuminuria testing and the novel meds in diabetes. Are there other things that you see on the horizon that you really think you'd like to see us help you improve in your practice or in patient care?
Well, once you figure out the data, I'd love to see automated kidney failure risk equation 2 and 5 years. Boy, wouldn't that be nice to have that, pop up on your Epic during encounters.
Yeah, do you routinely try to pull up those like the Tangri equation online or anything with patients?
Routinely, I don't do it at every visit. Another reason to have a microalbumin on the chart, by the way. But I try to do it once a year, twice a year. If I've seen they've been stable and they're low risk, and do I bother? It takes a little time, possibly not. Certainly, a lot of times I have to calm people down, right? You've seen this. They come from the primary care doctor. They told me I have kidney failure. Well, not really. And here's the risk. So yeah, I do find it useful, and I use it more than sparingly, I'll say.
Okay, no, that's great. Do you know offhand, is there an app for that?
Are you asking me? No, I have to go, I'm on my computer anyhow. So I go into Google, kidney risk failure equation pops up. I type the data in, it gives me, it gives me the answer.
Yeah, I've only ever used it online as well. But that's a great thought. Any other thoughts as to future areas you'd like to see us explore more as a collaborative? I certainly think that we will continue to work on SGLT2s and GLP-1s and hopefully see improvement. I think that's really a multi-year process for a variety of reasons, including the fact that not everything's in our control with coverages and everything. But certainly there's other new medicines too, like the MRAs, finerenone that have come along that seem to be very promising as well. So there's other medicines that we could look at in the future as well. So those are just other examples that, as we discuss, and this will be another topic for discussion in the fall as well, when we have our collaborative nephrology meeting to think about and explore for the future. So as I mentioned, one of the requirements for this year is to attend the spring regional meetings for your region. These are some of the dates. We will share these. I think these have already been shared, but we'll share them again. And we try to make this convenient for you to attend. So really, it's right about 6:30. Just want to thank all of you for coming and for participating and sharing your thoughts. We've been taking notes, and so we really appreciate the feedback, and lots for us to work on. So if anybody has any closing thoughts, otherwise, thank you very much for coming.